Our presenter today is Dr. Joe Sepulveda. We're so happy to have him back. Dr. Sepulveda is a CADTP favorite. He's partnered with us on many projects. He was a key speaker in our last DUI MAT Summit. He's attended and presented at CADTP webinars and is an all-around favorite. He has a very distinguished background and is a leading expert in substance abuse and substance abuse treatments. So with that, I'm very pleased to pass the webinar to Dr. Sepulveda and also to thank him for being here with us today.
All right, so welcome everyone. As it was said, we're going to be speaking today on a fairly large topic that takes several days, but we're going to try and distill it all within the next hour and a half. Topic being navigating the opioid and stimulant crisis, insights into addiction science and effective treatments. I'm Joe Sepulveda. I am the Chief of Psychiatry for Family Health Centers of San Diego, the largest federally qualified health center here in San Diego County. I'm also the Medical Director overseeing substance use disorders services for the organization and wear other hats within the organization and outside the organization. I have no conflicts of interest to disclose today. So let's start with getting a bird's eye view of where we're at right now with the opioid epidemic. And also we'll touch upon the stimulant epidemic that we're currently facing. And if you look at the slide here, what you'll find is we have overdose deaths. And you can see here all drugs associated with overdose that have been tracked by the Center of Disease and Control and then broken up into the most common substances that are found in overdose deaths. And what you can see here is that fentanyl is really the major cause of overdose deaths that we're contending with right now. And you can see that in the red line there. It's far outpacing any other substance out there. Second to that is methamphetamines, which you can see here in the dark blue line, followed by cocaine in the light blue line. And you can see heroin, which was really a big problem. And that was really the second wave of the opioid epidemic after prescription opioids is downtrending here. Again, fentanyl being the major offender. If we look at overdose deaths per race, and this is from 1999 to 2020, you'll see here that it changes based on the quote unquote 3 waves that we've had of the opioid epidemic. The first wave was really prescription opioids, and that took place in the 90s. This graph here starts in 1999, so we're not capturing that here necessarily on the graph, but if we were to have shown that, we would have seen that whites and Native Americans were primarily affected by the overdose deaths associated with prescription opioids back in the 1990s. The second wave hit where we transitioned from prescription opioids to heroin being the primary offender for opioid overdose, and that occurred about 2010. And what we saw there was consistent white and Native Americans were disproportionately affected. And then the third wave hit, and that's really when the synthetic opioids, quote unquote, fentanyl took over. And that was in 2013. As you can see here in the slide, that's really when that line shot up on the prior slide, but you can start seeing the demographics change here, where more blacks and whites were overdosing. And right around 2020, blacks and whites were overdosing at approximately the same rate as were American Indians. At a national level, if you look at the geographic map, you can see a clear difference between 2013 to 2022. Unfortunately, this difference is not for the better. It's gotten significantly worse. And you can see that here reflected on the heat map. Now, if you see here, West Virginia, unfortunately, has been very disproportionately affected as far as those that are contending with overdose deaths. But every state in the nation has gotten significantly worse when it comes to dealing with this epidemic. Now, one of the disturbing trends that we saw in COVID, when COVID took place, was that we started seeing more and more adolescents overdose due to fentanyl. And you can see that here on the left-hand slide, that's looking at overdose mortality among adolescents. And they're looking at specifically the specific substances here, which go from illicit fentanyls or synthetics, which you can see here on the gray line, is really far outpacing every other substance that is being tracked as far as overdoses, which are namely benzodiazepines, methamphetamines, cocaine, prescription opioids, and heroin. Now, the other thing that you can see here on the slide to the right is the ethnicities and how that's been affected as well. And what you can see here is that unfortunately, American Indian and Alaskan Natives have been disproportionately affected. But right around 2019 is when we started really seeing an uptick in others being significantly affected. Latinx, as you can see here, whites, and African Americans from an adolescent population. This is a big financial problem for the state of California, but also at a national level. And if you look at it, it's really in the billions of dollars that we're contending with this issue. And you can see it here broken down into the chart of the money that's spent on prevention, treatment, and supply reduction. Supply reduction, namely being enforcement or law enforcement, playing a significant role in trying to curb the epidemic. Federal funding has more than doubled since 2018. I mean, 2008, when it's come to fighting this epidemic. And in 2021, it's the first time that the federal government has really spent more on treatment and prevention than they have on supply reduction, or namely law enforcement, which is really a move in the right direction. We've been fighting the war on drugs for a long period of time. It hasn't worked. And really, what we need to be doing is treating this for what it is, which is a medical condition. Now, even though we're throwing this amount of money, it's still not enough to contend with what we're dealing with at the present time as far as resources for treatment and prevention. And this is timely now because approximately 6 million Americans are addicted to opioids. And those are probably conservative figures at the moment. At the present time, it's estimated that approximately 4 in 10 Americans know of someone who has died of a drug overdose. Now, where is this coming from? Well, when we're looking at fentanyl trafficking networks, a lot of the fentanyl obviously is coming across legal ports of entry. And you can see that here on the slide to the right. From 2019 to 2023, you can see that the seizures of fentanyl has increased year by year on a quite unprecedented rate. Now, keep in mind, the seizures that you're seeing here on this chart, as far as pounds being seized, are only what's detected. We're not detecting everything. And then obviously our streets are being flooded with fentanyl, but it gives you an idea of the gravity of what we're dealing with here. But nevertheless, there are three major players that are playing a significant role in the fentanyl coming to the US, and those are China, India, and Mexico. China is by far the main contender when it comes to providing the precursor chemicals needed to make fentanyl. They're mostly all coming from China. India has been playing an emerging role in that as well as being a source for the precursor chemicals. And Mexico is playing a significant role in quote unquote cooking fentanyl, or taking these precursors and developing it into fentanyl in order to make it into the US. Now, interestingly, not many people talk about this, but most of the fentanyl that's carried through US legal ports of entries are carried by American citizens. They're actually American citizens that are driving these fentanyl analogs or fentanyl itself that's already been cooked across legal ports of entry. And this is just a world map indicating what these trafficking networks look like. And you can see here that China is really the significant contender as far as being able to ship these precursors to Canada, the US, and Mexico. You can also see India here is playing a significant role, or an emerging role, and they're shipping much of their product to South America. Now, if you look at it from a domestic map here in the US, you can see that the vast majority is coming from the southern border, but not many people speak about this. But we also get fentanyl trafficked from Canada as well. So having spoken about fentanyl and having gotten a lay of the land of what it looks like from both a national and a world map, what is fentanyl? Well, fentanyl is a synthetic compound. It differs from heroin and morphine in that you really produce this in a lab. You don't have to farm this out and cultivate poppy seeds or plants in a large scale. You don't have to depend on weather. You don't have to depend on manpower for cultivating this stuff. So, in other words, to make morphine and to make heroin, it takes a lot of resources, a lot of money, and a lot of investment, and a lot of land to produce this. You don't have to do that with a synthetic compound that you produce in the lab. Now, most people, when they think of a lab, they think of this, a sterile environment where people are producing chemicals or drugs. But in reality, when we're talking about fentanyl, the word lab is really used loosely. And these are pictures of people that are quote unquote cooking or producing fentanyl from these precursor chemicals. And this is south of the border here in Mexico. And you can see picture on the left, upper left hand side where they're producing this out in the open. There's on the right hand side a jungle environment with somewhat, you know, a little more sterile conditions, quote unquote. And on the bottom, you can see what on the bottom left, you can see what's really produced here, which are large quantities of fentanyl from just a very small contained area. And you can see here a seizure of a warehouse south of the border that contained massive amounts of fentanyl that were destined to come to the U.S. Now, one of the reasons why we're seeing fentanyl play such a large role in the opioid epidemic and specifically in overdose deaths is because it is a highly potent substance. It's 50 to 100 times more potent than morphine, which is quote unquote heroin. And here on the left hand, upper left hand side, you can see equal potent doses of heroin, fentanyl, and carfentanil, which is even more potent than fentanyl. On the bottom left, you can see what's called M30 tablets. Those are also known as oxycodone tablets. These are counterfeit in nature and they actually contain fentanyl. But if I draw your attention to the bottom right hand slide, what you'll see here is 2 milligrams of fentanyl. And that amount is enough to kill the average American. So it doesn't take much of this stuff in order to produce or result in a death. Now, as I noted on the prior slide, a big problem is that a lot of substances nowadays are laced with fentanyl, or people are using a substance unknowingly that has fentanyl in it. They think it's something else. And this has been a big problem that we've been contending with. If you look at the bottom figures here, these are pictures from the DEA, and they show the difference between an authentic medication versus a counterfeit medication that contains fentanyl. And it's very difficult to tell which one is authentic and which one is fake. Now, you know, this is a big worry for people that are getting illicit substances on the street and they think they're buying, for example, oxycodone, which you can see on the lower left-hand side, um, Adderall, which is depicted in the bottom middle, and Xanax bars, which are depicted on the lower right. But every one of these fake or counterfeit pills contains fentanyl. And it's and it's also a problem that we detected back as early as 2014, where we started seeing fentanyl really mixed into a wide variety of substances. Um, Cocaine and methamphetamines were where we first began to see this. Cocaine really, because it's a powder substance and it's easy to mix fentanyl in there. It's a lot harder to do that with methamphetamines because you can see the crystallized version of methamphetamines on the upper right-hand picture. But when you see in the chart here is really around 2014, we started seeing a lot more positive uh, or positive samples of cocaine containing fentanyl. And right around 2015, we started seeing that uptick in methamphetamines or crystal meth. And again, it's harder to put it in crystal meth, but nevertheless, we have seen that. And of course, as you've seen on the slides prior, it goes on benzodiazepines or pretty much anything that you can put into a powder substance or that you can press into a pill formulation. So that's good and all. It's theoretical. I've given you a lay of the land, but what does that tangibly mean? I mean, how can we really get an idea or give a layperson a real understanding of what we're contending with? And I like to put this slide up to really drive the point home of what it is that we're dealing with. This is a seizure that took place in Alameda County back in April of 2022. This is more than 92 pounds of fentanyls that were seized. Now, 92 pounds, you can see here, is individually packaged. It's easy to move across different geographic locations. It's not a tonnage of material that you need to move. And this seizure alone, the 92.5s that were seized, is equivalent to about 42,000 grams. If we look at the DEA and what their guidance is, the DEA states that about 1 kilogram of fentanyl has the potential to kill about 500,000 people. So if we take the seizure alone and we do the math, and we take 1 kilogram, which equals 1,000 grams, we take this seizure, which was 42,000 grams, divided by 1,000 grams, we get 42 kilograms of product. We take 42 kilograms of product, we multiply that times 500,000 people, we now have 21 million potential deaths from this one seizure alone. And that's significant. Let's try and wrap our head around this. What does 21 million potential deaths mean? Well, if we look at New York and we look at the population of New York, it's 8.3 million people. Los Angeles, 3.8 million. Chicago, 2.7 million. Houston, 2.3 million. Phoenix, 1.6 million. Now, I've named at least 5 cities there. We're still short 2.3 million people to equal the 21 potential deaths from this seizure alone. Just to give you an idea of the scope of the problem that we're dealing with just this small amount of concentration that you can easily display and just take geographically all over the US. And this epidemic is evolving. It's not just we went from prescription opioids to heroin to fentanyl to adding things like xylazine, which is otherwise known as tranq. Tranq is a veterinary tranquilizer. It's primarily used for horses and large animals like deer. You can see that here from the label. It's an additive substance that people are adding to the illicit drug supply. Why are they doing this? Because it enhances the effects of the substances. For example, fentanyl, cocaine, methamphetamines, and other drugs. You either ingest it orally, you inhale it, you sniff it, smoke it, or inject it. And many do not know that this is contained within the product that they're obtaining in order to use. The major effects of xylazine or tranq are sedating. It lasts several hours and can often outlast other substances that they're mixed with. Now, this is a problem because if you're overly sedated, you can have nerve and muscle injury from remaining in the same position for several hours. It also lowers blood pressure, slows heart rate. But the major concern here is the increase in respiratory depression that can augment the other substances that you're using, namely opioids and fentanyl. And it significantly increases your overdose risk. The other thing that we're seeing with this substance is that we're seeing significant wounds in people that are using or have used a substance that has xylazine mixed in it. And what you can see here in the panels 1 through 4 is the progression of these wounds that you get from having used xylazine. And it's quite extensive. If you look at panel 4, you can see the significant damage all the way down to almost the bone. Panels 5 and 6 show what the healing process that can take place with significant wound debridement that happens in the hospital, followed by community management of the wound. So it is possible to get some improvement in this stuff, but it's significant. So having seen the problem from a national level, a local level, and just what we're contending with, how do we manage this problem? right? And one of the slides I showed you that a significant amount of resources are being put to treatment and prevention, and that really is the way to go. We need more of that. There's a large, there's years of stigma associated with addiction, and because of that stigma, addiction has always been dealt with as a societal problem, not a health problem. And the war on drugs is a perfect example on that, of how it's been dealt with. It hasn't worked. It hasn't worked in any nation that has implemented that tactic. What has worked is when you view this for what it really is, which is a medical disease. And if you treat it as a medical disease, then you have very good outcomes in the long term and short term when it comes to treating these individuals that suffer from addiction. So we really have to end the stigma. We have to come to the conclusion that this is a medical disease, which we've known for a long period of time. And we need to give these people that are struggling with addiction the dignity, respect, and resources that we have available, but are not being accessed because they're either prevented from accessing it because politicians have stigma against it, providers have stigma against it, the community has stigma against it, and even those that suffer from addiction have their own stigma associated with using medications and other interventions associated with treating addiction. If we look at the definition of addiction and how it's a medical condition, ASAM, or the American Society of Addiction Medicine, does a very good job outlining the years, decades of data that we have to show that this is really a medical condition. I'm just going to read this, but I'd like for you to focus on the bold areas here, because that's really what's driving home the message that this is a medical condition. And the definition is as such: addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic medical diseases. Okay, and this is really important. Now, usually I have an entire hour plus talk on just this definition alone to show people the evidence that we have behind all this, which is it's a treatable chronic medical disease. It's involving brain circuits, genetics, behaviors. There's ongoing use despite harmful consequences due to cravings, and how treatment is successful as a chronic disease. And you may be able to find that online. Talk I give specifically on that, which will be parsed down for the sake of time for this talk, but hopefully we get much of this addressed. So the first is that addiction deals with real biological structures, and there are changes in biological structures that occur just like any other medical condition. And you can see here on this slide, on the upper portion of the slide, there is a control, meaning someone that does not suffer from a substance use disorder. And on the right-hand side, there is someone that has a cocaine use disorder. And what you can see here in the green hue is metabolism of the brain. And you can see how the metabolism has changed significantly from the control on the left to that individual that suffers from cocaine addiction. This is no different than any other medical condition that we treat, meaning that there's an organ that undergoes changes that leads to dysfunction that then undergoes treatment in a chronic medical setting, meaning someone is seeing a provider chronically in order to treat that condition. So the example I'm juxtaposing this with is heart disease. You'll see on the lower left-hand side that there's a healthy heart. Obviously, there's been some changes on the disease heart on the right-hand side, and you can see the metabolic changes or damage that has occurred there as a result of the disease. Again, you go to a cardiologist, you get treatment, and you can improve. And that's really the message here is, even though there's biological changes, you can improve with the appropriate evidence-based treatment. Now, addiction, as far as how addiction works in your brain, has been well known for decades. It's been well mapped out. We know the circuitry in the brain that is involved in addiction. And if you look at the purple area here, this is really your reward area. I won't go into detail for the sake of time here, but it's a reflex art. We call this the reptilian brain. Why do we call it the reptilian brain? Is because of the reflex art. Think of an alligator, for example. An alligator has reactions, meaning that if food or something moves in front of it, it will snap because it knows every time it snaps, if it gets food, it gets dopamine surges, it gets a reward, and it knows to do that over and over again for survival. Well, this is the same reflex art that's involved in addiction. And this is why people develop cravings and compulsive use that they really cannot control. The green area here, or the one outlined as OFC, those are your frontal lobes. That's what makes us human and separates us from things like crocodiles, for example, that has a reflex art. That's your reasoning. That's the part of your brain that tells you you need to think about this. You need to stop. You need to process what you're doing. This is probably not a good idea. Move on. Well, the unfortunate thing is when you have an addiction, that drive or that wiring changes so much that you can see it in PET imaging that that purple area or that reflex art will shut down that green area or that reasoning area. You literally see the metabolism just shut down. So that's empiric evidence that people do not have volitional control over their use. It's driven by this reflex arc. And probably one of the best ways to describe this is a patient experience of what it's like to have these cravings and involuntary compulsive use. And this was taken from a USA Today article. Imagine having a woman in your office saying, and she's shaking her head and trying to hold back tears, saying, it's like God tells you that if you take another breath, your children will die. You do everything you can not to take a breath, but eventually you do. That's what it's like. Your brain just screams at you. And this really gets back to that whole reflex arc discussion that I was having with you just on the prior slide. Try to hold your breath. Even someone that wants to commit suicide or die, and they want to do so by holding their breath, they're unable to do so. Well, why? Because your brain, that reflex art, is overriding it. That reflex art is your survival mechanism and your guarantee that you're going to live and assure that you're taking a breath. You can't override that, right? So these people that suffer from addiction, they really need help. And fortunately, we have the science, we have the medications available to do that. But because of stigma, unfortunately, some people are against providing these medications, talk patients out of using the medication, either for a short or extended period of time. And patients, even if they go to things like NA or AA, are told that they should not be on the medications that are going to help them overcome this illness. So let's talk about medications for opioid use disorder. There are 3 FDA-approved medications for opioid use disorder. And what you'll see here on the right-hand side from top to bottom, we'll start with methadone, which is the longest approved. A very good medication for opioid use disorder, but it has to be received at a methadone clinic due to federal regulations. Then we have buprenorphine, which is a partial agonist. Buprenorphine comes, and it's otherwise known as Suboxone. It comes in a tablet or film formulation, and we also have a long-acting injectable formulation, otherwise known as Sublocade. Brixadi is another long-acting formulation that has recently came out in the market as well, and it's essentially buprenorphine. Works really well. And on the bottom here, you'll find the antagonist, which basically means it binds to the opioid receptor and prevents the binding of an opioid to the opioid receptor in your brain, and that's otherwise known as naltrexone. Naltrexone comes in a tablet formulation and it comes in a long-acting injectable formulation. Now, in the coming slides, we're going to be talking more about these 3 individual medications for opioid use disorder that are highly effective. But one of the first things to acknowledge, and which I've said before on other slides, is that there's a lot of stigma associated with people using these medications. And that should not be the case. And what I'm going to try and do in the following slides is demonstrate to you why that should not be the case and how these medications are no different than anything else we do in medicine. So let's start with the first stigmatizing thought that a lot of people have out there, which is medications for opioid use disorder is substituting one drug for another. Okay. If you look at the right-hand portion of this slide or graph, you'll see it broken down on the y-axis into three areas, which is euphoria in blue or turquoise, normal, which is orange, and withdrawal, which is in yellow. And normal meaning normal physiological state. Okay. Anyone who uses an opioid will go from normal to euphoria. We all have some form of euphoria. That is the reason why when we take an opioid, when we suffer a pain condition, we feel better because we not only get pain relief, but we have some euphoric effect. Now, some people are more predisposed or genetically predisposed to having more of a euphoric effect than others. But nevertheless, if you're on an opioid long enough, all of us have the propensity or the ability to become addicted. It doesn't mean that we all will, but we all have the ability to become addicted if we're on an opioid long enough. And typically what will happen is when you take an opioid, you will cycle from normal physiological state to euphoria, normal to euphoria, normal to euphoria. And that euphoric effect will start to downtrend. And that's because you're developing a tolerance to this medication. Eventually, what ends up happening is that that tolerance will turn into physical dependence, meaning that your body now is adjusting to this being the new norm in your life, meaning I need this in order to adapt or survive, continue to survive because your regulation in your brain has changed. And what ends up happening is you start going into withdrawal. If you don't have this, your body's telling you, I need this. So you go from normal physiological state to withdrawal. And this is usually where patients come and see me. And they will say time and time again, Doc, you know what? I'm not taking this stuff to get high anymore or euphoric or feel good. I'm just taking this stuff to feel normal and I hate it. And this is what they're referring to, right? Because if they don't take this drug, they will go into withdrawal. And what you can see here on the upper right-hand corner is what withdrawal really entails, which is vomiting, urination, diarrhea. You start getting the shakes, and it's not great. It's a horrible feeling. People want to avoid this at all costs. Now, what the medication does that I outlined on the prior slide is that they bring you back to normal physiology, namely methadone and buprenorphine. That's all they do. They don't get you high. They don't do anything other than bring you back to normal physiology so that you can go and live your normal life as just depicted on the lower right-hand side here. Well, how is this any different than what we do in medicine? Well, I hate to break it to a lot of people, but if many of you think that us doctors cure disease, that's not really what happens. The vast majority of the time, what we do is we take an individual that has an illness or a disease and we provide them medication so that they can live with their illness or disease in a chronic manner. Okay. So if we were to take the same chart, normal physiology, what happens is when you develop a disease in any organ system, you either overproduce something or you underproduce something. So thyroid disease, you are either overproducing a thyroid condition or you're underproducing a thyroid condition. Diabetes, you're either underproducing insulin or you're over or it's not functioning and you have some other condition where you're overproducing and that leads you to another set of issues. But what we're doing is we're essentially giving you a medication in all of those conditions and every condition that we give you in order to bring you back to normal physiology. That's essentially what we're doing. We're allowing you to live with your chronic disease. This is no different. The other thing that we often hear is people wanting to get either off the medication or being told that they should get off the medication that is working really well for those individuals, whether that be methadone, buprenorphine, or naltrexone. And what this slide here shows is that for individuals that are doing very well on the medication, they should not stop the medication. They should continue it. Again, you got to think of this like a chronic medical condition. Once you have addiction, you have addiction. The outcome really depends on how you manage that on a chronic basis. So if you're on a medication here for opioids and you continue that, you can see patients do very well. And this is depicting a study that took place for over a year. The minute you stop a medication that patients have been doing really well on, whether that's 1 to 3 months out, all the way to 12 months out, you do poorly. And that increases your risk of overdose and death. So make no mistake, if someone's doing well on this medication, they should not be encouraged to come off of it, because if you do or deny them this medication, you're essentially giving them a death sentence, is what's happening here. Now, back to the whole, mortality associated with opioids and fentanyl. What you can see here in this study is that there's a clear difference as far as benefit when it comes to mortality or decreasing mortality for those that are actually on medications for opioid use disorder. If you take the general population and you look at their death rate, and you look at people that are suffer from addiction and do not receive treatment for their addiction, you can see that they're at six-fold higher risk of death than the general population. But as soon as you give them a medication to treat their opioid use disorder, whether that be buprenorphine or methadone, you see that decrease back to what the general population is. So significant benefit that you get from this medication. So let's talk a little bit more about buprenorphine itself, otherwise known as Suboxone, which is a combination product, and we also have monoproduct buprenorphine. And here you can see that in this formulation, it's a film formulation. There's also a tablet formulation, both of which go sublingually under your tongue, dissolve, and that's how you take this medication. But this is a very interesting study that really gets the point across here. This is a study that was done in Baltimore, and it took place in 1995 all the way to 2009. And what you can see here is the red line is showing heroin overdoses in Baltimore. The line right below that, which is dashed with dots, that is methadone availability or patients on methadone. And the one below that, which is just a strict dash, that is buprenorphine availability or patients that were on buprenorphine or given buprenorphine. And what you can see here is between 1995 and roughly 2000, they were contending with a significant increase in heroin overdose deaths. And what they did was they increased methadone availability. Eventually, they increased methadone availability enough where they started seeing a downward trend. But again, methadone is not the easiest thing to access. You have to go to a methadone clinic, you have to go to oftentimes daily dosing. It's a very effective medication, but not the easiest to obtain for patients. As soon as buprenorphine became available, and that was through Data 2000, physicians in primary care settings were able to prescribe this medication just by going to a primary care physician and being able to have this prescribed, or going to see a psychiatrist. Essentially, any provider who had an X license at the time, which would require just some training, was able to prescribe this easily to their patients that were already impaneled to them. Now, we've done away with the X license. Now, theoretically, any provider can prescribe buprenorphine. But the point here is, if you look at 2000 to 2009, or I'm sorry, 2002 to 2009, and you see this availability of buprenorphine increasing and made readily available in the community, that is when we saw a significant decrease in heroin-related overdose deaths. So the point is, if you make these treatments widely available, easily obtainable, without any barriers, you will make a significant change in not only patients' lives, but your community and at a national level. So more and more people need to get on board with prescribing these medications and making them widely available. Extended release buprenorphine, also known as Sublocade, is essentially the same as what I just demonstrated to you as far as efficacy. When it comes to dealing with opioid use disorder, the only difference is that Sublocade or extended release buprenorphine is a long-acting injectable formulation that's given in the abdomen. It lasts a month, and it works really well for those people or those individuals that have a hard time either complying with oral dosing, have issues with oral dosing, fall out of treatment, or are at risk of losing their medications. So very good medication to use as well. So what's another question that I often get is, what should I use? Should I use buprenorphine or methadone? And which one's better? And the answer is either one. They're both great medications, and this study outlines this. Now, if you are on either buprenorphine or you're on methadone, whether that be high dose or low dose, you can see here that patients on buprenorphine will do better than those that are, or will do, excuse me, let me clear my throat here, will do better in general than low dose methadone. There is a small subset of patients that will benefit from high dose methadone a little bit more than buprenorphine, but for the vast majority of patients, they're going to do well with either or buprenorphine or methadone treatment. Now, that doesn't mean that they should switch from one to the other. If they're doing well with methadone, they should remain on methadone. If they're doing well on buprenorphine, they should remain on buprenorphine. If there's for a practical reason for why they need to switch from one to another, that's okay as well. But there's a risk associated with destabilization when someone is doing really well on a medication and you're switching them to something else. So it's just something to think about. But if patients are doing well, particularly if they're doing well for a number of months to years on a medication, it should be encouraged that they continue with that medication. Just a quick word on naltrexone, otherwise known as long-acting injectable Vivitrol. It also comes in a tablet formulation. We do use that for opioid use disorder. You can see here in this study that there's a clear separation from placebo as far as patients that are opioid free and a decrease in cravings associated with use. But it's a lot harder to start people on naltrexone because you have to have a washout period from opioids for at least 7 to 14 days, depending on whether you're on a short or long acting opioid. And a lot of patients cannot do that, whereas you can quickly place them on buprenorphine and methadone immediately. So something on our toolbox to use, but really the vast majority of people are going to do well and should be on buprenorphine and methadone, with a subset who may qualify for Vivitrol or naltrexone therapy. Lastly, when it comes to opioids, naloxone really saves lives and really should be given out to everyone who has either a substance use disorder, whether that be opioids or something that is not an opioid. Again, remember, there's a lot of illicit substances out there that are laced with fentanyl. So if they're suffering from some other substance use disorder, they should be given naloxone. Loved ones, if they have someone that's suffering from an addiction or opioid use disorder, they should have access to this as well. And the lay public, there really should be no reason, bottom line, for why someone should die nowadays from an opioid use disorder, because everyone should have access to Narcan, whether that's prescribed or you receive it over the counter. It's just, and every time you use Narcan or naloxone on someone that suffers an overdose, there is a significant increase in their motivation to seek treatment after suffering such an event. So again, something that really should be out there ubiquitously in the community and available. Okay, so let's shift gears here a little and let's talk about stimulant use disorder and treatments for stimulant use disorder. So When it comes to stimulant use disorder, namely methamphetamines and cocaine, what you saw previously with opioids was that there was a big emphasis in medications. And that's because the medications for opioid use disorder are very, very effective, incredibly effective. In fact, they're often more effective than any medication that you're given in either primary care or specialty care when you put them head to head. It's a little different when it comes to stimulant use disorder, whereas medications can help, but they're not near the level of effectiveness that we have for opioid use disorder. And what really is the gold standard for stimulant use disorder shifts from medications to counseling and support, with medications as adjunctive to help with dealing with this condition. Now, the psychosocial treatments associated with stimulant use disorder, or the evidence-based psychosocial treatments for a stimulant use disorder, fall into four categories that are highly effective. That's motivational interviewing, contingency management, community reinforcement approach, and cognitive behavioral therapy. Now, this is a summary slide outlining all of these psychosocial interventions that I just outlined on the previous slide. And in red on the upper part of this, you can see motivational interviewing, contingency management, community reinforcement approach, cognitive behavioral therapy. And this chart does a really good job of outlining what the focus of the practice is and all the other permutations of how effective this modality is for certain population groups or settings. The main thing to take from here is that these all have strong evidence base. They should be used for treating stimulant use disorder. And if you look at motivational interviewing, contingency management, community reinforcement, and cognitive behavioral therapy, what separates them and what's the difference between them? Well, if you look at motivational interviewing, it's resolving a client's ambivalence, feelings, or insecurities and enhancing their internal motivation for change in their behavior. And we'll go into more detail into all of these, but just to give you a brief summary, contingency management has more to do with positively reinforcing a desired behavior. Community reinforcement approach is identifying behaviors that reinforce stimulant use and making a substance-free lifestyle more rewarding than ones that include stimulants, or substances. And cognitive behavioral therapy is helping clients improve the quality of their lives, not by changing their circumstances, but by altering their perceptions of their circumstances. So let's talk about motivational interviewing. Motivational interviewing is a very effective tool, not just for dealing with stimulant use disorder, but any substance use for that that you're dealing with. Additionally, physicians that are dealing with chronic medical conditions could benefit from the tools of motivational interviewing to enhance the efficacy of their treatment, the compliance when it comes to patients adhering to treatment, etc. It's very effective, and it's something that I believe anyone who's in the field of addiction should be skilled in. So let's go into a little more detail. What is motivational interviewing? Essentially, what you're doing with motivational interviewing is you're evoking change talk in individuals, and you're trying to have an individual voice in their own words, their own motivation, and their own identified motivation for change to overcome the ambivalence for them undergoing that change. It's a process that is more likely to occur, meaning the positive change, if it comes from the individual itself. If they've identified it themselves, if they've come to their own motivation rather than having a provider tell them what they need to do. And there's no prescribed time period for this, meaning that it could take place over several sessions. It could take place over just one single session. It could take place over minutes or over an hour. It's really tailored to the individual. Now, if you'd like to get more resources on motivational interviewing, which I think everyone should have as a tool in their belt, You can go to the PCSS website. I've put links here that also give you courses and master level courses on motivational interviewing. And I know there's a lot of conferences that also incorporate motivational interviewing. California Society of Addiction Medicine is one, for example. But is really something that I think everyone should aspire to not only develop but perfect, especially counselors and those dealing with addiction. So let's talk about contingency management. Contingency management is really the gold standard treatment when it comes to stimulant use disorder, whether that be cocaine or methamphetamine use, and it has very robust data for it being incredibly effective at decreasing stimulant use. There's a couple of basic assumptions of contingency management that one should be aware of and know as to why it works so well. The first is that substances can be reduced using operant conditioning. What is operant conditioning? It's a learning process where voluntary behaviors are modified by association with the addition or removal of a reward. In other words, if you have a behavior that you're looking for, a positive behavior, and you reward that behavior, you're reinforcing that behavior. And that's essentially what you're doing with contingency management. It's useful in promoting treatment and retention and adherence. And the incentives for negative urine tests for stimulant use, namely cocaine and methamphetamines, is really what decreases the use. So again, if you're looking at contingency management, there are two things that you're targeting here. The first is the behavior, right? Whether that be the attendance to counseling or drug use, which is often goes hand in hand. You are reinforcing a person coming to the clinic on a regular basis and having negative tox screens or urine toxicology screens for the substance in question, which is cocaine and methamphetamine, and you're giving them a monetary reward, whether that be a voucher, movie tickets, some kind of prize in order to reinforce that behavior. So how is that practically done in clinic? And this is Nancy Petrie here, who unfortunately is no longer with us, but she is really the one that pioneered this and developed contingency management. And what you can see here is her fishbowl technique. And essentially what happens is you identify the behavior in question that you want to change. In the case of methamphetamines and cocaine, we want them to stop or decrease their use, right? So we're going to do urine toxicology screens, and the protocol is usually that you see them more often than not, usually twice a week, at the beginning of the week and then at the end of the week. You have a patient come in, they receive their counseling, they submit a urine toxicology screen. If it's negative, they then get to draw from this quote unquote fishbowl a prize. Now, in this fishbowl, there are large prizes. There are which can be up to $100 value. There are intermediate prizes. There are lower monetary value prizes, and there are affirmations, meaning like a pat on the back, you're doing great, right? But this is the part or the behavior that you're reinforcing is through this reward-based system, and you're substituting what they would have gotten from using cocaine and methamphetamines. And of course, if they're positive for stimulant use that week, then you withhold the reward, which is the ability to draw from this fishbowl. And what you can see here is that if you use this system, there's a clear separation between those that engage in this behavioral technique versus those that do not. So very, very effective at producing and maintaining negative urine toxicology screens for stimulant use. Now, the next psychosocial intervention is community reinforcement approach. So what is this and what are we doing? What you're trying to do with CRA is you're identifying behaviors that reinforce stimulant use, and you're making a substance-free lifestyle more rewarding than the one that includes substances. And you do this by utilizing a wide variety of multidisciplinary tools to do this. And you can see that developing relationships through counseling, vocational training for job skills, to re-engage in the community as a productive member of society, therapy and recreational activities play a role in this. So it's really trying to find a way for the patient to have a more rewarding lifestyle than they're using substances. And that's what community reinforcement approach is. Lastly, we have cognitive behavioral therapy here. Cognitive behavioral therapy essentially helps patients improve the quality of their lives, not by changing their circumstances, but by altering their perceptions of those circumstances. And there's this interplay here that happens with people that have negative thought processes or faulty thought patterns, which is, if you look at the right-hand side here and the schematic depicted there, if a person has a thought, it affects how they act and feel. If a person has an emotion, or if they feel negatively, it impacts the way they think and what they do, namely their behavior. That behavior then will also, if it's a negative behavior, will impact the way they think and their emotion. So you can see here that this triangle here, or this effect, feeds on each other, making a negative thought, a negative emotion, or a negative behavior worse for all the other permutations here. And what you're essentially doing is you're trying to have an individual change this pattern. This is standard therapy sessions usually take about 50 minutes for this modality of treatment and usually last over 5 to 10 months. But this is another effective tool that we have for dealing with stimulant use disorder. So, as I said, psychosocial interventions are primarily the gold standard or modality of treatment or the preferred intervention for stimulant use disorder. Medications help, and we can use that to augment the psychosocial interventions. Again, remember, in opioid use disorder, it, the medications are so effective that often this is the script is flipped, where we prioritize medications and we augment with counseling. But if we look at medications for methamphetamine use disorder, first of all, none of them are FDA approved for this. This is all off-label. But there are some studies that indicate that there are medications that may be beneficial when it comes to this regard. Now, when we look at naltrexone, or otherwise the long-acting injectable formulation of naltrexone and high-dose buprenorphine, there was a small effect based on a study that was published. So people can use the combination of long-acting injectable naltrexone, otherwise known as Vivitrol, in combination with the antidepressant bupropion, otherwise known as Wellbutrin. Mirtazapine has 2 small studies that indicate some efficacy in decreasing cravings associated with methamphetamine use. Bupropion, also known as Wellbutrin, showed some evidence for low-level users who adhered to taking the bupropion. Topiramate, again, for those that are low-level users, and naltrexone for those that had already stopped using methamphetamines for 2+ weeks, meaning naltrexone, the otherwise known as Vivitrol, just alone without the combination of bupropion. And then there's more controversial, well, controversial may be the wrong word, more debated modalities of treating this using stimulant medications. And this is highly debated. If you go to an addiction medicine conference, there's always a camp that says, there's a risk associated with this. There's another camp that says we should consider this. So it's not a straightforward we should use, but nevertheless, there's one small study that shows that dextroamphetamine, which is a stimulant, may be helpful. Methylphenidate also may be helpful for those that have moderate to high, at moderate and high doses, and may have a benefit. Now, when we look at cocaine use, there are a couple of medications, again, off-label, that may be helpful in dealing with this condition. Sertraline, otherwise known as Zoloft, is an antidepressant. For people that have abstained from cocaine or experience depression, it may be helpful in that population. Topiramate, also known as Topamax for lower level users. Modafinil, if a person has not used alcohol use, may be beneficial. And then again, it goes to those debated topics that I described earlier on the prior slide, which is using stimulant medications here. The real key take-home message here when it comes to stimulant use disorder is that one, you should avoid confrontation with these individuals. Well, why do I say that? A lot of patients do not identify methamphetamine use as a problem, which is completely different than opioid use disorder, as I depicted on the slide a while back, where they go into withdrawal and then they start coming into the clinic saying, I'm just using this stuff to feel normal, to avoid withdrawal. They're seeking help because there is a genuine, there's a problem, meaning that they've identified the problem physically. It's making them feel ill not having this medication. And that's why they come in to see me. Whereas people with methamphetamine use are using it recreationally. They often have some associated self-perceived benefits from it, meaning it increases their wake time, it decreases boredom, it increases energy levels, and that's often seen as a positive by those who are using methamphetamines. And then we have individuals that are using it for sex, for example, that in the LGBTQ plus community are they don't see it as a problematic. So that's why I say you need to avoid confrontation, provide education as to what the long-term risk associated with this is, which is psychosis and a host of other physical um, negative consequences that can occur from methamphetamine use. That allows you to build a therapeutic alliance with a patient or a partnership with a patient. And when you're able to do that, you're more able to effectively help that patient manage and navigate um, their motivation for wanting to uh, become substance free from stimulants. And again, this is where you incorporate motivational interviewing, and you meet the patient where they're at. If they're not ready to abstain wholeheartedly 100% off of stimulants, but they're willing to decrease the amount that they're using, that's fine. Start from there. Meet the patient where they're at. And then, of course, you want to implement the modalities of treatment, the psychosocial interventions that I outlined, which are motivational interviewing, contingency management, plus or minus community reinforcement approach, cognitive behavioral therapy, counseling plus medications is always recommended, and having frequent follow-up visits for these individuals to check in and see how they're doing, assess their motivation, continue having motivational interviewing with them in order to build upon that motivation that they've identified and had. And exercise. There's a lot of evidence out there showing that exercise may be as or more effective than medications that are used or prescribed for managing methamphetamine use disorder or cocaine use disorder, otherwise known as stimulant use disorder. So an exercise regimen can be very beneficial for this patient population as well. And one of the things I didn't put on here is mental health services is also very important for this patient population. Oftentimes, when they reduce or stop their methamphetamine use, there will be a period of time where they are more predisposed to developing depressive symptoms. Chronic long-term methamphetamine use can also develop psychosis, which will need antipsychotic interventions by mental health professionals, namely psychiatrists. So very important to do. And then obviously, trauma is a big part of addiction as well. That also is going to require mental health services. Um, and um, yeah, it's just very important to incorporate all those services. And obviously physical medicine as well, because this can also have detrimental side effects to one's cardiovascular system, namely your heart and other areas or organ systems as well. And with that, I think I'll end. Thank you very much for your time, and I hope this talk was beneficial for all of you. And please continue doing the work that you're doing. It's much needed. Thank you.
Great. Okay, I have just a few more questions here.
Sure.
This one's very interesting regarding with stimulant use disorder. Laura asks, are there any places in the US that are treating stimulant SUD with medical stimulants, so RX stimulants?
Yeah, so as I outlined on the last two slides, I believe, or three slides, there are studies that show that prescription stimulants are used in studies in order to help with this. And again, if you go into an addiction medicine conference, there's a camp that says that, we should be doing more of that. There's another camp that says that there's inherent risk associated with that, which there is, because you're given a stimulant to someone that has a stimulant use disorder, which works differently than the medications that we use for opioid use disorder. Um, so there are benefits. I mean, I'm not going to deny that there aren't studies out there showing benefit. But I wouldn't say that it's a recognized standard of care as what we've seen for example, medications for opioid use disorder, at
Thank you.
least not yet.
Okay, are there, and this is kind of a follow-up, but in a different line, and it has to do with stimulants. Is there a reason why folks with ADHD tend to use stimulants? And are there any good resources on the correlation between ADHD and stimulants?
Yeah, so I think this is, and if I'm reading the question correctly, it's asking, why do stimulants work for someone that has ADHD, and why is that the treatment of, or the gold standard treatment for managing ADHD? And specifically, we see this more in childhood where we treat with stimulants. Because it may not make sense that if you have someone that has ADHD, meaning they have hyperactivity, you're giving them a stimulant, right, which could produce hyperactivity. And this is a big topic. But needless to say, it was paradoxically found that stimulants for those that have true ADHD, and the reason I say true ADHD, and largely children, is because they've developed ADHD symptoms not secondary to some other um, manifestation of use patterns or etc. But they've developed ADHD and their wiring is different in the brain. They found it to be effective. Now, why? That's a whole like discussion conference and everything. But um, if I'm answering and understanding your question correctly, yes, stimulants are used to treat ADHD. They can be effective for ADHD, and it's a paradoxical reaction where you are given someone that has hyperactivity a stimulant, but you see a tampering of the hyperactivity.
Got it. Yeah, that's a little bit, it's hard to understand how that works, but it does. So,
Mm.
here's one from Herman. He says, can you talk about oxygen increase in helping in overdose?
Oxygen increase in helping an overdose.
Not
I think I'm
sure.
going to need a little more specifics on what it is that the question is asking. Um,
Got it.
just fishing here. If they're asking if someone overdoses and you are taking them to the emergency department and you intubate them and you're giving them oxygen, then yeah, I mean you're helping because you're oxygenating them. Obviously, it's the respiratory depression that is killing you and the lack of oxygen. But I'm not really sure what the question is getting at here. If they
Okay.
mean that, or if they mean if I'm giving oxygen via CPR, or if I'm giving oxygen via mask, or whatnot. I think what I'll say is if you have someone that's suffering from an overdose and they're in, the community or in the streets, the number one thing that you can do is Narcan. And especially if you're running like a clean needle syringe exchange program or a substance abuse program where you may have individuals who may show up and succumb to an overdose or have used this prior to coming, it's critical to have naloxone or Narcan around in those environments, even medical settings or residential treatment centers or whatever it may be. That's a one intervention that's going to be highly effective at reducing an overdose. And really, no one should die from an opioid overdose so long as you have Narcan around. If the second part of that question was, can you use CPR? Yes, absolutely. If someone, is has an overdose and you need to use CPR, then by all means use CPR. But Narcan is really something that should be around.
Okay. And how about alternative um, methods such as acupuncture? Someone wondered if acupuncture helps with people who use stimulants.
Yeah,
Or,
that's a good question. I think alternative therapies um, don't hurt. They may help. And Eastern medicine has always been shown to have some benefit when it comes to anything that you treat. And it's no different with substances, right? So if you're suffering from a pain condition and you undergo physical therapy, acupuncture, or other modalities of Eastern medicine to assist with that, and it helps, then by all means do it. The one thing or the one caution I would give people is when you look at those type of therapies, it should be used as an augmentation or an add-on to what you're doing,
Mhm.
which is what I've outlined here in this talk, which are the evidence-based treatments that we know for sure with certainty have efficacy and work really, really well with the substances that people are struggling with or the addictions that they're struggling with, namely like buprenorphine or methadone for opioid use disorder or the modalities of interventions that I outlined for a stimulant use disorder. Those should be the primary things that you should use for dealing with this. And adding what you suggested, acupuncture or whatnot, yeah, by all means, please, do that, especially if there's some benefit. But you shouldn't substitute those for what we know is the true gold standard or evidence-based treatments that we know from the literature.
Okay, and we had a little bit of clarification on the oxygen. It seems that there are some programs that are using oxygen tanks for overdosing from xylazine, which doesn't respond to Narcan. Is that correct?
Oh, I see what you mean.
Yeah.
Oh, yeah. So, um, let me take a step back here. Um, Xylazine is always, at least now, going to be found mixed in with a substance. You're not going to find people using this alone. So what I mean by that is the vast majority of patients who are going to succumb to an overdose at this period of time with xylazine are going to be mixed with fentanyl. Now, because you have those two components, you should use Narcan because what you're going to do is they're building on each other, right? They're decreasing your respiratory drive largely because you have fentanyl on board, and now because you have this additive that's also decreasing respiratory drive, which is the xylazine. So the Narcan will take care of the fentanyl, which is going to be a big part of what's going on with people that overdose. So you should still deploy Narcan. Now, if for whatever reason you're not seeing a reversal happen, with the Narcan alone, which suggests that it may be secondary to xylazine, then the first thing that people should do is call 911 out in the real world, right? And get emergency services there immediately with the tools and resources that they have available. But that's when you start deploying things like, for example, CPR, um, and other modalities of getting oxygen to the patient. Now, when it comes to literature and oxygen tanks, I don't really know the evidence behind one, what kind of oxygen tanks, flow rates, and all that is needed in order to in these specific cases, and when we're talking about xylazine specifically.
Mhm.
So I can't really comment on that right now as far as, what you should be doing and what type of oxygen tank, flow rate, and all that stuff. Um, but for those kind of situations, the tried and true method is one, deploy Narcan, two, CPR if needed, and three, make sure you call emergency services and get people there as soon as possible.
All right. Well, we have lots of positive feedback and thank yous to you, Dr. Sepulveda. It's very great to have you here today and to partner with us again on our webinar series. Your presentation was chock full of valuable information for SUD counselors throughout California. So
My pleasure.